So, good afternoon and welcome to the MIDAT session. It's a pleasure to be with all of you today. And I was looking, today is the February 29th, Leap Day, and looking into that, and this is, of course, you read it, the date and Roman numbers. And also looking into that, this is a leap year that starts on a Friday. Dominican letter CV of the Gregorian calendar is the 2016 year of the Common Era, or Anno Domini designation, and 16 years of the third millennium, and the 16 years of the 21st century. It's the 7th year of the 2010 decade. And interesting enough is the International Year of Pulses by the 68th session of the United Nations General Assembly on December 20, 2013. Year of Pulses, anybody's aware of that? No? Okay, well, and then the Food and Agriculture Organization of the United Nations has been nominated to declare the Year of Pulses, okay, which is interesting. Of course, the most important things, the major events, is June 2016, the class residence and fellow graduation. That happens to occur the same year of the Olympics, and the presidential election. So it's an important year, especially for some of us. Okay, so I'm going to start with a case presentation and share you a few cases. Hey, hi Alberto. Of a 39-year-old female, which HIV positive, Hep C, obstructive jaundice, and weight loss. This is an ultrasound of the liver, and would you like to take a look at this? What do you think you see there?
Sure. We've got two axial or transverse ultrasound images of the liver showing definitely left-side biliary duct dilation and also some, I'd say bilateral biliary duct dilation.
Very good. Excellent. Yeah, and that is called the too many duct songs. And what else?
And there's some here it's difficult to see. I see some academic material in one of the ducts. I'm not sure if that's air or if it's stone here.
Yeah, well, that's okay. It's very good. You saw the duct is a patient obstructive jaundice. This is the gallbladder.
There's a gallbladder and there's a
1.53 centimeters.
the neck of the gallbladder. It's not shadowing very well.
Yeah, but AIDS patients can have this, which is, let me see if I can have the house.
It looks like gas, actually now. It's like breakdown artifact.
Well, yeah, but this, remember, when you have an AIDS patient, this has been when the AIDS epidemic started in the mid-'80s, it was more widespread. They started seeing all these kind of weird or unusual findings. And AIDS was big in the differential of thickened gallbladder wall. Look at the CT scan of the abdomen.
So 3 axial CTs, contrast enhanced, 4 leading phase. The duct dilatation is on one side, 4 lengths of the duct, edema, big central hypotension liver, could be infection, could be malignancy, could be large things in the right setting.
Very good. So this patient has this mass there, center, mass there. The gallbladder wall, also by CT. So we decided to do first, what do you think the diagnosis in this patient? It's patient with...
So is it AIDS glandiopathy?
And the mass? What about the mass?
The thing, the AIDS could get infections, but I'm not sure.
Huh?
What's that? If it's not, if it's malignancy, I'd say some kind of lymphoma possibly. If it's infection in AIDS, anything goes.
Where were you trained? Yeah, well, you see the needle from the biopsy. And this is cytopathology. With all the red path you had, you should be able to make the diagnosis with this.
Small blue cell.
So it's a lymphoma, as you said. Yeah. And this is the ultrasound guidance. The bile ducts. And you can see a peripheral duct has been accessed. And we were able to go down. You see the big mass has a big bend in the big shoulder on the bile duct, and they have an internal external drainage. And this is, then after that, she got a PET CT, that you can see the uptake. And post chemotherapy at 1 month, you see how that bend has corrected, and the progression internal external drainage was removed after 2 months of chemotherapy. And the patient continued in remission, being managed by oncologist. So sometimes biliary drainage is temporary, when the causes are correctable. Well, so, and who would like to take this other one?
Somebody's got to take forward.
All right, I'll take it. I want to see what the images look like first before I.
Can you see from there? It's a 76-year-old male, jaundice and mild upper abdominal discomfort. On October 2005, had ventral laparoscopic cholecystectomy. And this is April 2006. Progressive obstructive jaundice. These are the labs. Total bili elevated, alkaline phosphatase 1,000, WBC 7,000. What are your thoughts? How would you study this patient?
Liver ultrasound.
Huh?
I get CT first, but probably ultrasound.
Well, we're going to do CT first because as you said. Good.
So he's got dilated biliary ducts.
How much? I mean, they are dilated, yes, a little bit. What else?
That talc clip doesn't look like it's in the right spot on the bottom of the frame, but maybe it's just catching it here.
Okay. Well,
Pancreatic duct's not dilated.
was that? No, that's fine. No, that's not a trick. Yes, it's that side dilatation, but it's not a humongous dilatation.
No.
Okay? What do you think about this?
That's concerning. Some kind of a
You had a laparoscopic cholecystectomy.
soft tissue mass. Could be an implant.
Yeah. Well, this is an interesting thing because patients that have laparoscopic cholecystectomy and appear with a mass at the skin, are usually patients that have had a history of some malignancy, or the malignancy has not been seen before. And this is the biopsy of the lesion. This is the needle is in here. And you can see the needle here, the biopsy. And was positive for cholangiocarcinoma. And this is the biliary drainage. As you can see, I mentioned to all of you the shoulders of the bile ducts, and the patient was in good status. The white cell count was normal, it was okay, so we just put a stent initially. This is the stent, this is the reconstruction, and this is at the clinic. After 2 weeks after that, patient was fine, the lab was resolved when we took the catheter out. And this is the patient ready to be followed up, which actually was a VA patient. This is a case of also a young man with AIDS at this time. This case is from California, and you had a gallbladder cancer that was attempted to be removed, but they were not able to take it out. So they sent us for us to do a biliary drainage, and you can see the right side that we use ultrasound to locate it. This is the sequestered right side, and this is the left axis where you see the needle in the very dilated left duct. Remember, the left duct are usually a little more dilated than the right ducts. And you can see it here going down to the common bile duct. And using guide wire and catheter manipulation, we reconnected both places and ended putting 2 metallic stents to relieve the jaundice. Of course, the prognosis of the patient was dismal. This is another patient, 72-year-old black female with CHF, hypertension, coronary disease, elevated liver function test. Patient was asymptomatic at the time, and a CT scan was done to evaluate her condition and an MRCP. And the MRCP shows, as you can see here, the right duct, that has an obstruction there. The left, this is the extrahepatic bile ducts that are normal in size, and the left duct were dilated. So this is the diagram of the lesion, and this is the sequestered right duct. We went down in here. When we went into the left duct, we could not communicate. This is the biopsy that we did, guided by fluoroscopy. We put a needle into this lesion, and this was a well-advanced Claskin tumor, and the result of the biopsy was cholangiocarcinoma. And this is the CT post-procedure. You see there is a little gap in between the catheters, and we use that gap to try to connect both sides. And here what we did is we will put a balloon catheter, and we punctured from the left side into the right side, and we connected both ducts. And then we placed different stents, and the thing is, this was not as fast as I'm telling you, but it took a few sessions, but everything went well. This is the patient when we have removed the catheters, and this is the bilirubin, how it came down until 2 months later from the initial drainage was normal. And the patient survived, surprisingly, years after this and died of her heart condition. Also, the biliary drainage can be used to manage duodenal obstructions. So you can use that access. This is a 40-year-old African American, also with AIDS and malignant obstructive jaundice for pancreatic cancer. Here you can see massive dilatation, metastasis and here, so it's frankly unresectable. And you can see here the drainage, the access. This wire is going to the distal duodenum. This wire is going retrograde into the stomach. This, you can see the obstruction is here. And this is after the reconstruction done on the same through the biliary drainage. Now, this is a patient with 53 years old, a bilacular from cholecystectomy, the normal cholecystectomy. Remember the cholecystectomy, laparoscopic cholecystectomy, the first one was done in 1987. In 1984, had hepatic jejunostomy. In December 1996, had bouts of cholangitis. Was managed like usually done with antibiotics only, and in 1997 had an image-guided intervention. This is a copy of the scanogram of the CT scan that you can see here. What they have done, they have put this. This is a Foley catheter. It has been cut. It's a T tube that has been put within the right and left duct and in the loop of the Roux-en-Y, and the surgeon wanted us to take it out because he didn't want to go back and operate her. So, do you think what would be the best idea? Because this was, as you can see, was a kind of a large T tube. So what we did, we look at the CT scan and look at this area here, and we look for the jejunal loop. We punctured this jejunal loop, we opacify it, we got access with 2 wires, and with an additional wire more, here is the puncture into the loop. These are the wires for access. we put a snare, we captured with the snare the tip of the T-tube, and here we're taking it out, with the clamp completely over the guide while we maintain the access. And this is the catch of the day. And this is the cholangiogram we did when we finished the procedure after years of the initial operation. That is very convincing about how good it is to have long-term the catheterization of bile duct injuries. So, when the laparoscopic cholecystectomy became more commonplace, the incidence of bile duct injuries, especially at the beginning, was quite prominent. And it was so that this article from 1997 said laparoscopic cholecystectomy, minimally invasive, maximally morbid. And this is one of the cases. The patient had associated also renal insufficiency. You can see here the hepatojejunostomy stenosed, had a renal transplant, lap chole, bile duct injury, hepatojejunostomy, obstructive jaundice. And this is the case initially. You see the stenosis there. We started the dilatation. We over-dilated it. And this is the follow-up before we remove the wire, after 8 months of having the drainage. Okay. This is a patient, one of the first patients I did here in October 1999, had an operation. Actually, had percutaneous, it was a lap chole. We repeated the procedure in 2000, and in March 2001, we removed the catheter. Long time, 11 months. So what happened with this patient? She is a 34-year-old woman, had a bile duct injury from lap chole, repaired with Roux-en-Y hepatojejunostomy. In March 2000, got progressive obstructive jaundice, managed again with antibiotics, and then came here with persistent jaundice. And this, what you see here, are the clips from the cholecystectomy, and this is the loop of bowel. But you see the bile ducts, typically, they are in the laparoscopic cholecystectomy bile duct injury, they are not very dilated. And that is presumably because the patient has bouts of cholangitis that are subclinical, and the liver becomes a little harder. And so we did the initial drainage, peripheral duct. You can see here with ultrasound, and you can see the clips from the cholecystectomy, little passage into the loop. We cannulated the ducts. We dilated the bile ducts and the anastomosis. And this is in the follow-up that was asymptomatic after the drainage, got electric repeat dilatation and catheter replacement on May 2000, but had a positive pregnancy test on June 2000. So we decided just to leave the catheter left there and wait until the patient delivers. Here's the patient at the clinic, with a catheter. And it's a drainage catheter only, not biliary, because you don't need a biliary catheter when you have that just. And Jordan was born in January, and this is the follow-up. Here we have, this is the biliary catheter. Here you have the passage. We took it off, and that is the tract that formed in those 11 months. And the patient has remained with no big problems in them. I have not seen it again. So what I learned from this case, biliary drainage catheters are well tolerated. You can tolerate the whole pregnancy. Prolonged catheterization favors patency of a stricture hepatojejunostomy. And interestingly enough, biliary drainage catheters are not reliable as contraceptives. So I'm going to talk in this leap year, in this February 29th, we're going to need to wait 4 more years for another February 29th, about image-guided percutaneous biliary interventions. The objective is to encourage a multidisciplinary approach to manage biliary patients, and we do that in our hepatobiliary conference. Review indication, technique, and results of these interventions, and to provide tips for general planning and management of patients requiring specific biliary interventions. So which patients benefit from percutaneous biliary interventions? Obstructive jaundice and bile leaks. We know, and all of you, the residents, are very familiar with the multidisciplinary team approach with the surgeon, gastroenterologist, diagnostic radiologist, interventionist, and an oncologist. And this is a picture of the initial hepatobiliary team. These two surgeons are in Willis-Knighton now, but the rest of the people, you can see us with a little younger faces. Number one, uncomplicated obstructive jaundice is not an emergency. We do not rush to decompress these patients until they are fully evaluated. Number two, the hepatobiliary diagnosis, the diagnostic workup should be non-invasive. Ultrasound, CT, MRI, nuclear medicine, CT PET, or PET MR. Diagnostic ERCP and PTC are passé. This is all things. MRCP bile duct anatomy images are accurate and reliable for treatment planning. You have seen some of the cases. The biliary team decides hepatobiliary patient management, and they will deal with the benefits and problems if something happens. So the definition of image-guided percutaneous biliary intervention are minimal invasive procedures indicated for management of obstructive jaundice and biliary leaks. The purpose is to divert the bile externally when the patient has cholangitis, or to reestablish internal bile flow through manipulation with bicatheter, balloons, stents, choriolythotomy, or foreign body removal. So the percutaneous biliary drainage can be done through the bile ducts, the percutaneous biliary drainage, or the gallbladder, percutaneous cholecystostomy. Balloon dilatation may be necessary for biliary structures during cholangioplasty and anastomosis. Stent placement for permanent opening of the thing. However, they are now resorbable stents. I have played with them this time when I was at the beginning of the month in Spain. They are made by a Polish company called ELA, looking at FDA approval, and choriolythotomy, removing stones. And miscellaneous for body retrieval, brachytherapy, etc. The obstructive jaundice bottom line is biliary drainage. External could be nasobiliary or percutaneous, internal, endoscopic, percutaneous, or surgical. The bile leak bottom line, stop the leak, evacuate the collections, reestablish bile flow to the intestine by endoscopic, percutaneous, or surgical means. So in 2010, SIR, in the Standards of Practice, defined the quality improvement guidelines for these procedures, and this is the team that worked there. Joan Wahak is from from Lafayette. She's a very nice lady, likes horses. And here you see the reported rate and threshold for major complications for transhepatic cholangiography and biliary drainage, which is sepsis, cholangitis, bile leak, hemorrhage, pneumothorax, reported is 2%, and the threshold, as usual, is a little higher because it allows you, to be a little more than has been reported. The other major complications, intra-procedure and post-procedure, here they are cited. The range goes from sepsis, hemorrhage, inflammatory infections, less than 3%, transgression of adjacent structures, colons, bile 1.6%, death 2.5%. Remember, many of these patients, especially if they are infected, they have at risk of having a bad outcome. And the post-procedural inadvertent catheter discontinuation requiring de novo cholecystostomy and/or surgery. There is no consensus about what was the rate, but I can tell you that probably, especially for cholecystostomy, this is one of the highest, the most frequent complications that we have in that. So the process of percutaneous biliary drainage has a pre-procedure evaluation, preparation, and planning, procedure performance, and the follow-up. Pre-procedure patient evaluation is clinical, imaging, and the laboratory, liver function test, CBC, coagulation parameters. Patient preparation, nothing by mouth, corrective coagulopathy, antibiotics, and hydration. The antibiotic we use if the patient is clinically not infected. Prophylactic we use cefazolin 1 gram IV, and usually better to give it about 2 hours before the intervention. The real fact is usually the patient has it on the table. Doesn't seem, although not to affect too much the outcome. Patient clinically infected or suspected to have an infection. should be on therapeutic doses of antibiotics, ciprofloxacin, imipenem, etc. You need to discuss with the rest of the team what to use. Remember that failed ERCP biliary drainage patients are considered infected by definition because they have been instrumented. Coagulopathy correction, and this is important because it happens all the time, and fluorescent plasma immediately before, during, and after the procedure. Is something that we do. We start before we do the procedure, during the procedure, and after the procedure, especially in biliary cases. This is not a little thing. This is a major procedure. Platelet transfusions are given during the procedure because the lifetime, useful lifetime of the platelets is very short. The doses of these compounds are tailored to the patient's coagulopathy.
Dr. Dave,
Yeah.
thresholds for the previous slide.
Yes.
Like 1.5 or
No, 1.5 is okay. 1.5 by definition, and remember, the coagulopathy parameters that you need to use are the coagulopathies given by the standard of care of the SIR. Why? For two reasons. Number one, they are very reasonable, they are very safe. Number two, if you run into a problem, legal problem, which I don't ever like to talk about those things because you're not working thinking about you're going to have a lawsuit. You need to be working thinking about what is the best thing I can do for this patient. So 1.5 is super safe. You should not give them anything. You cannot give it just in case. Remember also, blood products are expensive and are risky.
so you would prefer vitamin K in a situation?
What's that?
Vitamin K.
Vitamin K, always. Remember the patient that have jaundice with, you need to, as soon as someone calls you with obstructive jaundice, you should give him 10 milligrams of vitamin K, and the dose is 10 milligrams. Not PO, because the patient is jaundice, so the vitamin K is not going to be absorbed in the intestine. You give it intramuscularly or subcutaneously, 10 milligrams daily for 3 days. If you have the time. Sometimes you don't have the time.
Right.
But if you have a normal liver, the liver will pick up in about 8 hours to 12 hours. Thank you for the question. So the planning. The plan is a little, as you see, prolonged of focus, but this is important. What is the general condition of the patient? Is the cause of the obstruction benign or malignant? Are the intrahepatic bile duct dilated? Where is the location of the obstruction leakage? That the patient has cholangitis? Am I capable to carry out all or part of the procedure? Do I have the personnel, all the materials, and adequate imaging for safe performance of the procedure? And remember, if you don't plan well, you are bound to have surprises. Failure to plan is planning for failure. This is Ben Franklin. So anyway, what is the general condition of the patient? Patient in good general condition, you may do a single-step intervention and resolve the patient's situation. Drainage, as you have seen one of the cases I've shown you, and or if the patient is inoperable, suffering from malignant jaundice, if he can stand one-step procedure, you can use it. If you're in doubt, go to 2 stages. Patient in poor general condition may only tolerate just a quick procedure for biliary decompression, external biliary drainage or percutaneous cholecystostomy. Is the cause of obstruction benign or malignant? Benign biliary obstructions as well as bile leakage may require repeated percutaneous or combined manipulation. Usually, you will know a lot about those patients because you'll be seeing them many times. Malignant obstructive jaundice may be resolved in 1 or 2 stages of procedure. Are the intrahepatic bile duct dilated? Moderate intrahepatic bile duct dilatation facilitates puncture and intrahepatic bile duct access. These are the best. These are easy. You go, the wire will go where the obstruction is and no problem. Massively dilated intrahepatic bile duct with elongation and tortuosity are simple to access. However, it will be very difficult for you to navigate through. Non-dilated bile ducts make us consider diffuse liver or ductal diseases that prevent ductal dilatation. By this time, you have confirmed the patient does require drainage if you are already that you need to do it, but you are going to face a very challenging biliary drainage. The conditions in non-dilated bile duct that may require biliary drainage: obstructive jaundice, liver cirrhosis, NASH, non-alcoholic steatohepatitis, cholangiocarcinoma, diffuse, sclerosing cholangitis, or bile leaks, postoperative, and laparoscopic orestectomy or post-traumatic. In the patient with obstructive jaundice with non-dilated ducts, consider percutaneous cholecystostomy if the gallbladder is distended, because it indicates that the obstruction is distal to the cystic duct, and you may decompress these patients just putting a catheter in the gallbladder. If the gallbladder is not distended or absent, if not distended means the obstruction is more proximal to the cystic duct, so you will have a challenging biliary drainage. And when you get into the bile ducts, you need to try to go down into the duodenum because you will not have room to put a pigtail catheter in the intrahepatic bile ducts because they are not dilated. And external biliary leak, usually try to do a cholangiogram, inject catheter or sinogram through the skin hole and proceed according with the findings. That will allow you to puncture the bile ducts intrahepatically. Where is the location of the obstruction and leakage? High lesions, intrahepatic, bile duct confluence, Claskin tumors, are more challenging to achieve drainage. Several catheters may be needed to drain multiple sequestered intrahepatic bile ducts. Never think about more than 3 catheters. 3 catheters max. Otherwise, the patient is very uncomfortable. It's going to be very challenging for you too, and it's not a good thing. Low lesions are usually single. They are initially managed by endoscopy or surgery. The percutaneous biliary drainage is required when ERCP fails or the patient is not a surgical candidate. This is the Bismuth classification for benign biliary strictures. And this, as you see like this, is not casual, it's not fortuitous. This is the diagram that Bismuth himself draw, okay, and his signature. Different types of bismuth. The type 1 to type 3 almost, these are easy to fix, with the hepaticojejunostomy. This requires opening, especially the left duct, and these higher ones require more doing an anastomosis between the intrahepatic bile ducts and the jejunal loop in more than one location. This is Bismuth classification by his drawings of malignant biliary strictures. And again, when you have a little nubbing, in the confluence, that makes the reconstruction much simpler. Remember that when they do the hepaticojejunostomy, the surgeon tries to go as high as possible to get a big mouth in the biliary tree and to secure that bile duct wall is going to have circulation, because the most common reason why these sutures fail is because they have ischemia and then they retract and the scar closes the anastomosis. So access to intrahepatic bile duct right or left, that depends on the location of the biliary obstruction, operator's preference. In general, people that have trained without using too much ultrasound, they will go from the right side, And that thing is changing because now almost everybody is accustomed to use ultrasound, but that is traditionally was the cause. Different anatomy, atrophy of the segment to be drained precludes the access. Sometimes you have a cholangiocarcinoma that compromises the portal vein. Usually that segment of the liver will be atrophy, and you have dilated ducts, but you are not going to be able to see it because you're going to be too much posterior if it's the right side, or too much into the midline if it's the left side. So the approaches, on the right side, you usually are guided by anatomical landmarks, although some of us prefer ultrasound guidance. I think it's easier and also is nice because many patients that have obstructive jaundice have hepatomegaly, and sometimes you can do a right percutaneous biliary drainage subcostally on the right side, and then most of the time it's intercostal though, which is painful, has a risk of thoracic complications because of injury to intercostal vessels, or you can pressure on the nerve there, pneumo-obiliothorax, and empyema. These things happen to all of us, unfortunately, once in a while. The left side is ultrasound guided, is subcostal. The axis is anatomically anterior to the bile duct, confluence, and common bile duct, which means that when you inject contrast, directly goes down and flows down into the common bile duct and the distal bile ducts. The access to intrahepatic bile duct to effectively decompress the biliary tree, high structures above or involved in the biliary conference, you need to do a bilateral access. If the obstruction is below the biliary confluence, and unilateral access suffices. Many times you can get by with only one side, and you have seen some cases, and then you need some manipulations also to get access to. And here you can see high intrahepatic biliary obstruction above or involving the biliary confluence, and you can go right or left, or both of them, and you can use segment 7 or segment 6 on the right side, and usually the segment 3 is the one you'd use for the left side. When you do a unilateral biliary drainage access, if you have access to the left side, you know, I prefer to use the left side, and if not, the right side on the 6 if possible, and if not, the segment 7. The issue with segment 7 sometimes is high, and the risk of thoracic complications is higher. Planning, that the patient has cholangitis. Patients that are presumed to be infected include benign obstructive jaundice, gallstones, sclerosing cholangitis, postoperative structures, bile leaks, previously instrumented or with biliary stents. All these patients, you need to think the patient is infected. Patients with malignant obstructive jaundice may have bactibilia without clinical or laboratory manifestation of cholangitis. Bactibilia in these patients occur as high as in 40% of these patients. Patients with life-threatening cholangitis, they need hemodynamic and respiratory support. It's good to have anesthesia on board, IV antibiotic coverage, and do an external biliary drainage or percutaneous cholecystostomy. And if the patient is too sick, just do it at the bedside. Avoid unnecessary manipulation. You don't want to have a big cholangiogram. Just a little bit of contrast to make sure that you're there, or nothing, and you put a catheter. Am I capable to carry out all or part of the procedure? And this is for, especially if you are starting your practice, you don't have a good support around you, you know, you have, these are the assertive actions upon a challenging case and limited operator experience. And this includes consultation with a colleague with more experience, requisition of assistance for the procedure. It's not bad to ask, please give me a hand here, okay? I want to do it, would you mind helping me? And most of us will be delighted to do it. A referral to a center with more resources and experience in pathobiliary teams. This is okay. Do I have the personnel, all the materials, and adequate imaging for safe performance of the procedure? Percutaneous biliary drainage is among the most complex procedures in non-vascular IR, where the operator's experience plays a major role for success and low complications. And this is true. You know, it's important that people know what they're doing. Lack of trained personnel, materials, or good fluoroscopy warrant transferring the patient to a center where those resources are available. Okay, don't hesitate, patient come first. Anesthesia. The anesthesia, we do it most of the time with procedural sedation, sometimes general anesthesia. It seems that the patient is so sick now that we are using more general anesthesia than before. And of course, in children and non-cooperative patients is a must. And local anesthesia, of course, for the puncture incision. Image-guided ultrasound and fluoroscopy. The materials we do in standard interventional table. The needles for access, usually Shiva 20 or 22 gauge, 10 or 15 centimeters, depending on the size of the patient and your access. Access set and vascular sheaths. This depends on your preferences and if you have it available. Guide wires, you know, guide wires, regular guide wires and glide wires. Catheter locking pigtail, always something to secure the catheter inside, 8 to 10 French. Balloon dilatation catheter if you need it, stent self-expandable in case you need it, basket, brushes, etc. So the access set, it has a little component with a fine needle and the later sheet system that goes from 6 to 8 French. The guide wires, the J wires, hydrophilic or amplas, especially amplas to put the stents. The catheter is a locking pigtail for external drainage suffices, it's like an abscess drainage, and biliary catheter is for internal-external drainage. The balloon dilatation catheters, usually you use 6 millimeters to 10 millimeters in diameter by 40 millimeters in length. With 40 millimeters is more than enough usually to cover your hepatic ostomy or a tumor stricture. The stent, metallic self-expandable, usually 8 to 10 millimeters in diameter. The length can vary. There are covered and uncovered stents. You know, the uncovered stents have less chances of migration. And the covered stents, if the patient supposedly will last longer. Baskets, when you need to do a cholecystectomy, remove stones from the common bile duct, and snares for foreign body retrieval, like had happened in one of our patients, that when Simon is not here. You need to remember that case. Patient and operator position. What do you put when you want to do biliary drainage? In general, these patients are done in supine position. The right side may be a little slightly elevated, about 30 degrees, when you're going to do the right-sided approach. The operator is always on the side of the drainage, like in nephrostomy, when the drainage of recollection, gastrostomy, so forth. On the right side of the patient for right peritoneal biliary drainage and cholecystostomy, and on the left side of the patient for left biliary drainage. Occasionally, the gallbladder protrudes too much to the left side, and you may have a direct approach to the fundus from the left side. So the steps are intrahepatic bile duct approach selection. You need to select it with ultrasound or CT or IRCP, MRCP. Access to peripheral duct. Peripheral duct, why? Because you have less chances to have a bad complication. Bad complication is puncturing the hepatic artery. The portal vein can pretty much benign, doesn't complain too much, but you touch the hepatic artery and you're going to have a pseudoaneurysm. Aspiration of 1 milliliter of bile for stat gram stain and culture sensitivity for bacteria and fungi, and inject a diluted contrast to have a PTC or cholangiography to see where you're going. Insert a 0.018 inches guide wire, needle skin and soft tissues hole enlargement to get the introduction set, the access set, and insertion of a guide wire. There's going to be a guide wire that will help you to do the rest of the intervention. You put a biliary drainage catheter with internal fixation device, locking pigtail, something that secures you. Otherwise, between the respiration and the abdominal wall, that catheter will come out. Secure the catheter at the skin. In our population, the best thing is a suture. And you can add an external fixation device. A 3-way stopcock for irrigation and connect to the drainage bag, especially open in external biliary drainage. What are your post-procedure orders? For pain control, usually intravenously, and morphine sulfate or 2 to 4 milligrams IV Q4 hours would be okay. If not, Demerol 50 to 75 milligrams IV. Nutrition, return to oral feed is tolerated. The activity tailored to patient performance plus incentive spirometry. Remember, this is good. Increasing the oxygenation helps the patient to blood return to the heart, prevents thromboembolism, and so forth. Continue antibiotics to complete treatment. I use ursodeoxycholic acid in all the patients that work in the biliary tree, in practically all the patients. 300 milligrams PO BID, which corresponds to a dose of 10 to 15 milligrams per kilogram per day. IV hydration as needed, and catheter irrigation orders you flush the catheter with 5 or 10 milliliters normal saline. So in short term, when the patient is here, evaluate the patient's general condition, vital sign, chest and abdomen. The Brown code, does he have a BM? Labs. Every time you put a catheter in the abdomen, check if the patient moves the bowel. Drainage drainage volume, the characteristic bile color, is it blood, is it pus? Check catheter skin entry site for leakage, infection, and if the catheter and bag are secured. Most of the catheters that will come out, usually initially they don't come out. And many times you have seen it in your cases here, that they are hanging from the little pigtail, very peripheral in the liver. In the clinic, you check general patient condition, check the meds, if he's taking it, evaluation for catheter removal, additional procedures, drainage volume, characteristics, etc. Check the catheter skin entry site for the same reasons that we check the inpatients. When do we remove the catheters? The biliary catheters and cholecystostomy catheters need to remain in place for at least 14 to 20 days before the catheter removal to allow formation of a mature walled-off tract from the gallbladder to the skin. If you take them earlier, because our materials have very little effect, they don't elicit a lot of inflammatory response in the body, so that makes that walled-off inflammatory tract takes longer, and there's a risk of intra-abdominal bile leak if the tract is not formed.
We do a catheter cholangiogram, cholecytocholangiogram, to evaluate for passage of contrast through the bile ducts into the duodenum or bowel. To see if it has strictures or feeding defects. And prior to removal, the patient must tolerate 48 hours the peritoneal biliary drainage and the cholecystostomy tube clamped. That is a good biologic test to see if the patient can get can tolerate the catheter outside and not have problems. And we reported this many, many months ago. So after we remove the catheter and everything, we schedule clinical imaging follow-up appointment tailored to each patient condition. You know, in general, the patients that should worry more are the patients that we have had malignancy or the patients that have bile duct injury. Benign stricture is scheduled at 1, 3 to 6 months, and then yearly. Malignant obstruction 1 up to 3 months, and we see. PVD then for malignant biliary obstructions, poor patient condition, or cholangitis, initial external peritoneal biliary drainage, metallic stent for reconstruction, or oxycholic acid for life. You know, post-lap chole bile duct injury, unilateral or bilateral peritoneal biliary drainage, over-dilate hepatic jejunostomy, long-term catheterization, 6 to 12 months. And in summary, safe and effective performance of image-guided biliary intervention requires a multidisciplinary approach for assertive pre-procedure patient evaluation, preparation, and planning, technique tailored to each individual case, consistent follow-up for learning on the long-term results of the intervention, and has a major role in effective palliation for patients with malignant obstructive jaundice, controlled resolution of postoperative anastomotic stenosis on patients that underwent bile duct injury repair, and in acute cholecystitis, good for decompression in non-surgical patients. I just want to honor my mentors in hepatobiliary pancreatic diseases. This is a picture we took many years ago in San Diego. This is Larry Curry. This guy wrote a book, The Pancreas, that I bought when I was in Argentina doing surgery that taught me how to see pancreatitis. You know, he taught me the 3 stages of pancreatitis, severe pancreatitis, and so forth. This, you know what this guy is? We named it, eh?
I'm not sure.
No, it's not Trump. No, it's Henri Bismuth. Henri Bismuth is of Jewish extraction. He was born in Tunisia and practiced in Paris. He is the guy that put intraoperative ultrasound, especially intraoperative ultrasound of the liver, in front line. This is Babs Musa. He was the chair of surgery at UCSD when I was the chief of the non-vascular service there. This is one of his residents. And this is Marshall Orloff. Marshall Orloff is the person in the United States that have more experience in the world, you know, with portocable shunts. You know, and we had, one of the things we did at that time was a trial between TIPS and portocable shunt surgery for all comers. It was a very red project. So anyway, the International Year of Pulses, this is what it is, you know. An International Year designation provides an unprecedented opportunity to raise awareness and to celebrate the role of beans, chickpeas, lentils, and other pulses in feeding the world. Even more importantly, it will be a galvanizing moment to draw together key actors to further the contribution pulses make to health, nutrition, and sustainability. The FAO intends to make people more aware of the nutritional value of pulses, of their contribution to sustainability, and more reliable food. There's a cooperation within food production systems to use protein in pulses better, promote production of pulses worldwide, improve crop rotations, and improve trade in pulses. But this is what it was. I learned something, you know. And this is what it looks. Actually, I thank you all. Cross Lake, you know, and there's a little bayou. You may know this, Linda, when you go in the north. Yeah, there is an opening. This is the bayou, it's a beautiful place. Thank you so much. Any questions?